Ahead now to the next talk by Josephine Tecklenborg, another talk from the University of Exeter. This title is a type 1 diabetes diagnostic model, including type 1 diabetes genetic risk score and clinical features aids in the classification of adult patients with clinical type 1 diabetes that are islet autoantibody negative. Josephine, please.
Thank you for inviting me to present this abstract on behalf of my co-authors listed. So classification of diabetes is difficult and misclassification is common. However, correct prediction of diabetes type is essential to ensure adequate treatment that minimizes side effects and is cost effective. Generally, diagnosing clinicians classify the diabetes type by looking at the clinical features and then confirm their suspicion using biomarkers. So what happens if we have a patient that we suspect to have type 1 diabetes, but is islet autoantibody negative? Does that change our management plan? And what can help us make those treatment decisions? In order to help with this, we aim to assess the utility of a type 1 diabetes genetic risk score alone or within a diagnostic model to assist the classification of diabetes type in those patients who had clinician diagnosed type 1 diabetes that were antibody negative. So we studied 152 white Europeans within the DARE cohort, 60 of which were autoantibody negative. And they all had clinician diagnosed type 1 diabetes as indicated by insulin treatment from diagnosis. We calculated a type 1 diabetes genetic risk score, as well as a probability for true type 1 diabetes using a combined clinical risk model, which included the genetic risk score, age at diagnosis, and BMI. And now we evaluated them for the outcome of predicting absolute insulin deficiency with a C-peptide of less than 200 picomoles per liter at 3 years duration as a marker of true type 1 diabetes. So overall, both the type 1 diabetes genetic risk score and the diagnostic model were good at differentiating diabetes type. And you can see in this receiver operating curve in blue the genetic risk score, and you can see that in red the diagnostic model has a greater area under the curve, adding increased discriminative value. And you can see the clinical usefulness of this in this distributional graph of the model probability, with a low model probability for those with retained insulin secretion on the left compared to a high model probability for those with insulin deficiency on the right. Therefore, in conclusion, we can say that the type 1 diabetes diagnostic model is a useful tool in aiding classification and making management decisions in adults who have clinical type 1 diabetes but are autoantibody negative. This was a small cross-sectional study, so we're currently validating this in a larger longitudinal cohort with patients followed from diagnosis, and we're looking to evaluate in other ethnicities in the future. Thank you, and I'm happy to take questions.
All right, Josephine, thank you very much. You want to drop your slide set down now, please. Good. So the diagnostic model really performed really well, and validation is always important, as we've mentioned in a previous talk. What was your level of C-peptide that you determined? Why 200 picomoles?
So in previous studies, this has been shown to be a good marker of, it shows that there is very low insulin secretion after that, and that in previous studies has been shown to be a good sign of sort of true type 1 diabetes, and it's been previously used as one of the indicators in that model as well.
Those levels were obtained in the fasted patient, correct? That was not after a meal or glucose stimulus. Is that correct?
In the cohort study we studied, it was a random level, but certain markers use glucose, meal stimulated C-peptides. So there are some variances in that, and it needs to be addressed with that.
All right, good. Thank you very much. Let's go ahead and move on.